There you go. Thanks, Jasmine. To welcome everybody. Everybody looks like they've muted themselves, that's great. If you'd like to make a comment, you can stick up your hand or you can unmute. Or there's also the chat to please respond in the chat. There'll be questions and discussion topics. So I think that we'll start with Dr. Kathryn, who is going to start us off with presentation. Over to you, Kathryn.
Thanks, Gillian. Thank you. I'm just getting my slides up. Okay, can you see my screen?
Yes.
So let's put it in presentation mode. There we are. Okay, so hi everyone. So my name's Kathryn. I'm a palliative care specialist. I'm working for MSF at the moment, based in Amsterdam. And I was asked to give this session on palliative care for patients with HIV and advanced HIV. And I just want to say before starting that I'm not an HIV specialist. So there will be lots of things that I might not have the answer to that you may have questions to. You have questions about, but if there are questions, specific questions, for example, about medications or particulars about HIV that we don't have the information on, we can do our best to get that to you. And the focus of the talk is really about the palliative care needs for people living with HIV. So the session will be run like this. So we're going to have a quick look at the role of palliative care when caring for patients with HIV. We will look at some of the very common symptoms, so pain and other common symptoms for patients with advanced HIV. And we will think about some of the psychosocial and spiritual issues that these people face, and then go on to think about prognostication, so how we understand these patients' prognosis and the challenges of that, and a little bit about medication management at the end of life. And it's going to be tricky to go into depth with a lot of these topics. So again, if there's any additional information you want after the session, I can get that to you. So please do request if you think, oh, I want to know more about managing the symptoms, for example, so we can share more information after the session. So fortunately, with the arrival of antiretroviral medications, HIV infection, advanced HIV, which is what we often call AIDS, so stage 3 and 4 HIV, is more like a chronic illness now for patients who have access to ARVs. But we know there are many people that don't know their status, that are living with HIV and haven't had a test. And also we know there's still people that do not have access to ARV antiretroviral medication for maintenance therapy for HIV infection. And we also know that poorer communities tend to have higher rates of HIV, and they tend to have poorer survival as well when they are infected with HIV. And this is in part due to the delays in diagnosis, but also barriers to accessing care, which we'll talk a little bit about later, and problems with, which can also have potential problems on their compliance with medication. So I'm just showing here this graph just to give you an idea of numbers. So you can see here there's an estimated around 40 million people living with HIV globally, and you might have heard of the 90-90-90 or 95-95-95, which is the aim of UNAIDS to try to reach these targets of 95% of people knowing their living with HIV, knowing their HIV status, 95% of people on treatment, and then 95% of people also having their viral load suppressed. So this is showing you the target, where the estimate of where we're up to in terms of that. So there's still some way to go to reach those targets, to make sure that people are being tested and having access to drugs, and having access to drugs that are effectively suppressing their viral load. I can share these slides after the session as well, in case you want to look over this in more detail. So the WHO has said that all people living with HIV should have access to palliative care throughout the course of the illness. And so we know that symptom control and providing good holistic care improves actually disease outcome for patients living with HIV, because it improves adherence to their medication, to the AR antiretroviral therapy, and also their maintenance and staying in an HIV program as well. So the role of palliative care is really to, as a sort of part of routine care, is really to think about improving symptom burden, and we'll talk about that in a moment, focusing on quality of life and not just CD4 count and viral load and not just the disease. It's about improving disease management, so it's effective in terms of adherence, as I mentioned. It's about improving coordination of care between different people who may be involved. And also it facilitates end-of-life care for people who have HIV and are at end of life. And I just want you to think now about your workplace, and if you have people, if you are looking after people who are living with HIV, and if you have patients with advanced HIV, and I just want you to have a think about the problems that they might have. And I'm just going to leave that with you, and I'm going to suggest you please feel free to type in the chat, and we can pick this up at the end. But just reflect on this as we go through the session, and we'll come back to these questions at the end. And I'd be really interested to hear about the patients you're caring for. So when we think about the symptoms that patients living with HIV, and in particular advanced HIV, have, it's important to remember that the symptoms might be due to HIV infection itself. It may be due to the opportunistic infections. So patients who are living with advanced HIV, with low CD4 counts, and the different opportunistic infections that they're at risk of, or it can even be due to the treatment itself. So we know that antiretroviral medication have a lot of side effects too. So we need to think about this when we're thinking about symptoms to try and understand the most likely cause of symptoms. And in terms of patients who do not have access to ARVs, either before ARVs were available or in settings where ARVs are still not available, we know that many of the symptoms are due to the opportunistic infections. So that's when patients tend to become symptomatic. And some of the most common symptoms, and we'll go over these again in a moment, are sort of headaches, and we think about cryptococcal TB meningitis, sort of the wasting and abdominal pain, which can be caused by different infections, but MAC infections one, systemic MAC infections one, breathlessness and cough, of course, TB being very common, certainly in many settings where patients are having it, certainly in Bangladesh. TB would be a common co-infection, I imagine, but I'd like to hear from you on that. It certainly is in India, where I've been involved in caring for patients with advanced HIV. And blindness, so CMV retinitis may cause that, and symptomatic anemia is very common for patients who are not on ARV medication. And I just bring up here this table from a systematic review, and I think this is from 2002, but I will check. And this really just shows the common symptoms for patients with advanced HIV. And I think what really strikes me about these figures, so this is different studies, and it gives you a range, a prevalence range, which basically shows what the different studies found the prevalence of each of these symptoms. And I think what really strikes me is, gosh, how high these figures are. So pain, between 30 and 98% of studies found that pain was a key symptom. Anorexia, so loss of appetite, 82%. Fatigue, tiredness and weakness, up to 95%. Breathlessness is very common as well, around half. Insomnia, half to 3/4 of patients have that. Diarrhea is common too. So, and look at the psychological symptoms. So depression, low mood and sadness, up to 82% in some studies, and anxiety as well. Up to 3/4 of patients were suffering from anxiety. So I think it just reminds us that patients with advanced HIV have often a heavy symptom burden, And I think the other thing I just want to mention here, while I think of it, is we need to remember to ask, because sometimes for different reasons, people may not share the symptoms they are feeling. They may just sit with them. And I think it's really important not to just think about the disease, but actually to think about the suffering that is associated with the disease too. So we'll have a look over pain first in a bit more detail before we have a quick look at a few other symptoms. So pain is common in advanced HIV, and I've put around 70%. It's different in different studies, but around 70% of patients with advanced HIV have pain. And of course, this can be due to the HIV infection, which is often associated with neuropathies. It can be due to opportunistic infections, and it can be due to malignancy, of course, which is more common in immunosuppressed people. And it can be also other conditions too. And I think the point of this is just to highlight that there may also be multiple sources of pain, and there may be different pathologies. And it's just trying to work out what is the most likely cause of that person's pain. And we're going to go over a little bit in detail about pain, but it's not going to be, you may still have more questions, and please do write them in the chat if you have any that you want to ask as we go through. So the thing to remember is that we need to ask about pain. If we don't start asking, we often don't know. And patients may not know that you can give them medication to treat their severe headache, let's say, or other pains they may have. And we know it can have a huge impact on the patient's quality of life by reducing the suffering. So I'm going to have a quick run through some of the common pains that patients with advanced HIV may present with. So peripheral neuropathy is quite a common one, and can be on the feet and in the lower limbs. And you'll remember, those of you who have had some of the sessions on pain, you'll remember something perhaps about neuropathic pain, which can be different in character. So it's a sort of burning or shooting pain or numbness. And this neuropathy can be caused by HIV infection itself. Okay, so and it can be in various forms. So you can have a mononeuropathy, or you can have more of a sort of systemic neuropathy, more like a Guillain-Barré syndrome. But what complicates things is that you also have quite often co-infection with TB for patients with advanced HIV. And we know that some of the TB medication can cause neuropathy too, isoniazid as well as other drugs. So it's important to try to get a really clear history so we can try and understand what's the most likely cause of the neuropathic pain. And of course, some patients will have other conditions too, like diabetes. So it just goes back to having a really good pain assessment and trying to find out the most likely cause of the pain. Abdominal pain is also quite common for patients with advanced HIV. And again, this can be caused by bacterial and parasitic infections, particularly for patients with stage 3 and 4 so advanced HIV, but also can be caused by medications, and the protease inhibitors can cause abdominal colic. So again, key in the history to find out when the symptoms started. And pancreatitis is associated with HIV as well, because of the one of the hyperlipidemia that can occur with the antiretroviral medications and the antiretroviral medications, but also cotrimoxazole, which most of the patients take as a prophylaxis. So just to remember that one as well. And of course, malignancies, we need to be thinking about if patients are presenting with new symptoms. So I'm not going to go into too much detail, but just to give you a flavor of some of the other common pain presentations. So headaches are really common, and certainly I'm thinking in India, and I haven't got a lot of experience with advanced HIV in Bangladesh, but certainly cryptococcal meningitis was, cryptococcal infection was very common. And TB meningitis was fairly common presentation for patients with advanced HIV. And I know this varies depending on different countries and different settings. But if patients are presenting with headaches and you find a diagnosis of HIV, and they have low CD4 counts, or you suspect advanced HIV, then we should be thinking of these conditions. And of course, as well as that, malignancies or other causes of headaches. So herpes is common as well as in patients who are immunocompromised, and this can be sort of herpes zoster, so the shingles infection, so the dermatomal pain, oral herpes, and genital herpes as well. So one other to highlight is chest pain, and we think about PCP is quite a common presentation for patients with advanced HIV, so atypical pneumonias, and of course TB. And very common as well is quite significant oral candidiasis. So we need to think about that for patients with mouth pain. Have a good look inside. Do they have the abscess ulcers? Do they have candidiasis? And this is all treatable, and that improves their pain. And like I said, malignancy, we need to remember that patients who are immunocompromised are more susceptible to malignancies too. So very briefly on pain management, just to say that recall the pain assessment and management trainings we've done in the past, and how you treat the pain depends a little bit on the most likely cause. We've got our WHO ladder, which I've just put a copy of it here. And if it's neuropathic pain, you may go to some of the adjuvant medication, so amitriptyline, gabapentin. And again, if you need any more information on that, just let me know. We know that for patients with HIV, if they haven't been on antiretroviral medications before, controlling the HIV infection is quite often a very good way to control a lot of the symptoms, certainly from the opportunistic infections. So treating the opportunistic infections, starting ARVs, and just trying to pick up if there are malignancies. I know there's not often treatment for the malignancy, there may not be treatment, but just trying to understand the likely cause. And we give analgesia. And I've just put a reminder here about some of the non-pharmacological ways of supporting pain management. And this needs to go alongside analgesia, not as an alternative, unless the patient doesn't want analgesia, but these are to complement analgesia for patients with pain. So relaxation techniques, mental imagery or visualization. So you can give these techniques to people to try to control and manage their pain, as well as analgesia. So just a quick run through some of the other common symptoms for patients with advanced HIV. So fatigue is very common, and it can have a significant impact both on quality of life and on mood. So patients who are very fatigued are also very prone to depression. So as with all symptoms, we look for treatable causes, and common ones with HIV infection are anemia, depression, which may be associated with patients with HIV, and side effects of medication. And most of you will probably have guidelines on management of HIV where you're working. And this will give guidance on what to do if you find, for example, anemia and someone's on Zidovudin, which can cause anemia. It should give you then a plan of what to do if someone has a severe anemia. And I hope you have those guidelines in place where you're working. If not, I'd be interested to hear about national guidelines and if you have access to those. So chronic diarrhea is also very common. And I think we need to take this symptom really seriously as we do with pain, especially for patients that maybe don't have easy access to sanitation or have poor sanitation where they're living in the camps. So we need to really look for the cause and treat this as we're able to. Nausea, it can be caused by many of the antiretroviral medication. There's a couple that are particularly emetic, which is Zidovudin and the protease inhibitors. But some of the others can cause, like a hepatitis, for example. We've got nevirapine and efavirenz can cause a hepatitis, which can present with nausea too. So it's just thinking about the medications, thinking about, could this be medication related? And again, then it's a question of going back to your guidance and seeing what the recommendation is at that point. Do you have access to second line drugs or not? Dysphagia, so a painful swallow, and this is commonly due to esophageal candidiasis. There are other causes too. Dry and itchy skin, and so just think about checking for scabies in particular, because I know that it's particularly common in the camps, and treating other infections and making sure that the people have access to emollients for dry skin. And just remember about the skin changes of Kaposi sarcoma, so the many sort of purple-brown nodules that can come all over the body that are characteristic of Kaposi's. Okay, so just very briefly, just to mention about the fact that antiretroviral medications have many interactions with different drugs, and certainly with some of the symptom control drugs. And some of these are just, a lot of these are just be aware of this interaction rather than don't use the drug. Okay, and so I've just put here some of the common interactions. So with protease inhibitors, some of the drugs that we often find ourselves using for symptom control in palliative care can interact with the protease inhibitors. So if you're starting I think the bottom line, what I would recommend, if you're starting any new medication in patients on ARVs, I always just go to this drug interaction tool, and I've put the link for it at the bottom of this page, and I'll share it with you. So this is just a way of typing in the drugs that the person's on, and it just comes back with the interactions and the different level of interactions. So you can see, is this a good drug to start, or should I look for an alternative one? Yeah, so it's just being mindful of that, and I'm sure that's probably already in your practice, those of you who see patients with advanced HIV. So I just want to have a think about the psychosocial and spiritual support that's needed by patients living with HIV and advanced HIV. And before I do, let me just check the chat to see if there's any comments that I want to bring up. Thanks, Erin, for putting that already in the chat. Okay, so yeah, Erin's saying these patients have a high symptom burden. Yeah, that's true. So do put anything you want in the chat, and we can pull it into the discussion. Okay, so the multiple sort of psychosocial issues to consider for patients living with advanced HIV. And the first is that they have a life-threatening illness. And this in itself, you know, is a huge stress. And that's before we think about some of the other stresses that people living with HIV often experience. And these include the stigma and discrimination that are often common within the community and also within healthcare systems as well. And it can be really a barrier for people to come forward and get tested. It can be a barrier for people to take up treatment. There are often very sort of strong emotions associated with diagnoses of HIV, and these can be around anxiety and fear, and also anger. And I think a lot of this stems from the mode of transmission of HIV. And so what does this have on the communities and within the families in terms of even disclosing HIV status? Okay, so it's not just when a person finds out they have HIV, it's not just about the impact on themselves, but also the impact on their family and how they will be seen by others. And there's often fear of rejection. There might be a fear of infecting others in their family. And there can be often quite complex feelings of anger or sense of betrayal, or how has this illness come into our family? Yeah. And certainly when I was supporting the team in Bihar province in India, there was often a real sort of sense of shame at having contracted the disease. And so there's a huge burden for people to carry on top of the uncertainty of having HIV as well. And how will they cope? how will my family cope with this disease? And I think it's particular for HIV. That of course there are stigmas with other conditions, but I think the HIV stigma is particularly challenging for many patients, and often associated therefore with HIV, people have low mood, and they very commonly have anxiety and depression. And so often these patients need will really benefit from support from the mental health team if you have access to it, and if it's acceptable for them to have a space where they can talk about all these different emotions that this will bring up, the diagnosis will bring up. And the mental health team that I was working with in Bihar really said to me, we do a lot of work just trying to help people with their self-esteem and their confidence, just try to build their self-esteem and confidence up, because often that's very low. And it's also about helping to adapt people to living with this new diagnosis of HIV. And it's also about supporting the communication with the family, and about rebuilding those relationships that can be damaged when this diagnosis is made within a family. And the other thing that can be quite helpful with HIV is peer support. So it can really be an important part of the psychosocial HIV care. And if a person is well enough to engage with that, just having a contact with someone else who is living with HIV and has lived with, who can understand the experience and the challenges that the person may face, can really be a big support. So sort of a peer support group, and that's something that might be something that mental health teams where you're working can think about introducing if it's not there already. And the other thing to say, and I think this is around spiritual support really, is that often when people are faced with a life-threatening illness, it's very normal to turn to your faith or your spiritual practice for support. But unfortunately, the discrimination and the stigma can also exist amongst the religious communities or in social communities. So it might be that if people reach out to their usual support systems, they may face rejection, they may face criticism, or if they don't, they may fear that they would. So they may not reach out to their usual sources of support. So it's important to have these conversations around this to see if people feel they can access the support that might usually help them. And if you're seeing a lot of patients with HIV, or even not a lot, it's about thinking about how can this person access what we call non-judgmental spiritual support. So how can we sort of either sensitize or do education support for religious leaders, religious communities? How can we engage with traditional healers to help to reduce stigma in the community? Or it might be that the spiritual support is something that is done within the team because and taken forward by one of the team if a person doesn't feel comfortable to access their usual support system. Okay, just a couple more slides because I'm aware of the time as well. So another challenge of advanced HIV is that the prognosis in the post-ARV, so since we have access to antiretroviral drugs, which is, we're very fortunate to have access to these, and I hope you do have access. What it means is that it's often quite difficult to know when someone presents as a first presentation of advanced HIV in a critical state. It can be really difficult to know if this person with ARVs, with treatment for the HIV, as well as opportunistic infection treatment or what's needed, if they will improve. And people can come in really sick, but with a bit of time and the right treatment, they can walk out. the hospital and do well and be maintained on their medication. So it can be difficult to know. I think the point is it's difficult to know until quite late if someone is going to improve or if someone is going to continue to get sicker and die. And I'm talking about the acute presentations here in particular. So I think it's important to think about palliative care certainly in parallel with active treatment. So early on, we need to be thinking about having the conversations about what people's priorities and preferences are. And this can be quite difficult when you're not sure how someone is going to do on treatment, but you can phrase this in a way to say that while we really hope that with this treatment you're going to get better, we also would like to have these conversations, and we have these standard conversations with people to understand what they want, what you would want if you don't get stronger from this. So that's something I think important to do early. And certainly in Bihar, it was really important for people to go home for end of life in Bihar province in India. It was very important for almost all of the families, all the patients and families wanted to go home for end of life care. And so it was important to know and have these conversations early so that if possible, that could be planned for. Even if you know, rather than starting these conversations when you realize that someone isn't going to recover. So that's what I would recommend. Really start palliative care, so the symptom control communication early on, and do active treatment and palliative care together for your very critically sick patients. So if you don't, for patients that don't access ARVs for whatever reason, the median survival after having an advanced HIV defining condition is around is less than 2 years. Okay, so that just gives you an idea of the prognosis if you don't have access to ARVs. And of course, for some people, their prognosis will be determined not by the HIV infection or opportunistic infections, but actually by malignancy, for example. And so that might be a clearer prognosis for some people. You might know, actually, this person has a malignancy, and if we don't have treatment for that, they will certainly disseminate a malignancy. They will get sicker, even if you control their HIV. Okay, and I think this is my last slide. So just a few comments about medications at end of life. Sorry, I'm just going to put you on mute because there's a bit of an echo. So just to say that if you have treatment failure, you should really try and advocate for second or third line treatment if that's available for you. And do write in the chat about your access to ARVs in your setting, in your projects, and also your access to second and third line treatments as well, so we can know what you have in your setting. And if we for patients who are approaching end of life, if we decide it's time to stop the antiretroviral medications because they're no longer having a benefit, this should be discussed with the patient. And it's important to do this because there's often quite a significant tablet burden with ARVs, and it can be quite difficult to take oral medications, especially for patients who have whether swallowing difficulties or pain in their mouth from candidiasis. And some patients do benefit from staying on ARVs to maintain viral suppression, but this is not relevant if the prognosis is short. So that's viral suppression for symptom control. Similarly with opportunistic infections, usually for patients approaching end of life, you can stop prophylactic medications, and often the symptoms from the opportunistic infection wouldn't necessarily increase in towards end of life. If they did, it might be it's trying to figure out the benefits and burdens of those treatments. So this is really individualized care to see if if there's having a role in symptom management. So in short, any medication which is helping with symptoms you would continue as you would in other parts of palliative care, but it's particular for the if they don't have a role and they're not helping with symptoms, then they can certainly be stopped. And involve the patient in the discussions about stopping treatment. Sometimes these decisions are made with chart review, but it's really important to go back to the person who is used to taking all these medications, knows they have a role in their health. So it's really important to sit down with them and discuss their preference and make a decision and a plan together on which treatments to stop and when. Okay, so I feel like I've done a lot of talking. I hope that was useful. I just want to go back to one of my earlier slides and just ask you to reflect on this. So are you caring for people with HIV infection, and are you seeing patients presenting with advanced HIV symptoms? And what problems do they have? What problems do they face? And if you can share in the chat. I know we don't have a lot of time, so I'm going to hand back to Gillian, and we'll see how much time we have for questions now, or whether we wait till later on. Okay.
Let's do a few minutes. Thanks, Kathryn. Let's do a few minutes of questions. There's a comment in the chat that Erin has answered about whether you can combine antiretrovirals and chemotherapy, radiotherapy, and Erin has answered yes, you can. Obviously, you need to look at drug interactions. Any other? Oh, I see a hand up. Junaid, go ahead, unmute yourself and go ahead.
Hello, Kathryn. So as working as a palliative hospital in Guadalmara MSF, so we have an ITFC corner, and we have a regular patient with SAM. Sometimes as a routine screening program, we do the retrovirus for all the SAM patient, and we have few cases with positive retrovirus. So on that case, should we consider them as a palliative case, as those cases are not in advanced stage, but as you mentioned in the earlier slide, every HIV patient should be considered as palliative one. And furthermore, what should be the ideal approach for those cases? I mean, for the pediatric child especially.
Hi, Dr. Junaid, and thank you for your question. So if I've understood, it's around pediatric patients that have routine HIV testing who are presenting with a severe acute malnutrition.
Yes, we do routine tests
Yeah.
all the patient with SAM.
Yeah, of course. So I'm not a pediatrician, but what I would recommend is absolutely to have the palliative care approach also for these children. And what I mean by that is that we are absolutely, and I think it would depend, of course, on, is this the first presentation with severe acute malnutrition? Is this a child who is not having recurrent and not gaining weight? Are they starting on ARV medication? So there's lots of questions that will come in that will help inform how you manage each individual case. But I think what we can certainly do is have this palliative care approach. And what I mean by that is that we think about symptom management, and we ask, I mean, of course, it depends on the age of the child, but we can ask them about, what's most difficult for them, if they're in pain, if they're feeling sick. So we can ask them about their symptoms, and we can treat those, absolutely. And we should do. And I think the other thing we can do is around communication. So taking the time to sit with the family and sit with the parents and understand. And of course, depending on the age of the child, I'm imagining a child under 5, but of course it might be an older child as well. And just exploring with them, their experience of this condition, that do they have a diagnosis too? How can we support this family? So really taking time to listen, use your communication skills, your active listening skills, and just understanding, and they may need some additional support from the counselling team, because they're living also with this new diagnosis. Because probably if the child has, perhaps one of the parents has a diagnosis. So it's a huge, I'm trying to find the right word. The walls have been blown apart from the family with this diagnosis just suddenly popping up. And they may not have known that one of their parents had it already. So it's a huge, not only worry and fear for their child and the outcome of their child that's now got HIV, but also the impact, as we talked about, in the community and the stigma and everything else that they have to face. So I'm going to just see if Megan wants to add anything in there as our pediatric palliative care specialist.
Thank you, Kathryn. I agree. I think that, just to clarify, Junaid, so you sometimes give palliative care when you think, okay, this child's going to die, like for sure from this condition. And that I'm trying to say, well, that might just be end of life care. You might think they're going to die quickly. So if you have a child who has SAM, who you incidentally diagnosed with HIV, they might not be in that category where it's like end of life care. The counseling you do is not going to be like telling the family like this child's going to die like in the next few weeks. But they do need palliative care in the sense that they're at high risk of dying in the future. They're not going to live probably a normal lifespan, given that they live in a refugee camp and they have HIV and severe acute malnutrition. Remember, like SAM on its own has a 40% mortality. So overall, globally, might be better in your setting, but so SAM is not good. Then you add HIV. So you have a child who's at a high risk of dying. And they're having a huge burden, like Kathryn said, of symptoms and of psychosocial suffering. So for those reasons, you implement a palliative care approach, like Kathryn said, where you need extra support, they need counseling, they need extra support to manage the illness. And because we know that if you don't give them palliative care, they're going to die sooner because they don't get enough support to continue potentially curative and treatments that help with the disease, like help with the SAM and help with the HIV. Does that make sense?
So I'm just great. So it's Shalene. I'm going to move us along now, and we can talk more about this at the end if we've got some time, because we still have the case presentation. There are comments in the chat, so please take a look at those as well. Thank you, Dr. Kathryn. So we're going to move over to Dr. Lucy, who is going to give us the case presentation. And Lucy, I'm going to let you share your slides. Maybe you should introduce yourself.
Okay, yeah, sure. Hi, everyone. My name's Lucy. I'm a paediatrician from the UK, and I'm working in Bangladesh in Golmara Hospital for the past 2 months. Let me just share my slide. Okay, can you see my slides?
Yes.
Excellent, thank you, great. So I'm going to present a case today that caused us a lot of thought, called A New Unsafe Swallow. So the key questions and sort of thoughts that we had from this case that I want you to think about whilst I'm presenting is how should we safely provide nutrition to this child who has a new unsafe swallow? Also, how could we manage this child's spasticity? And do you feel that there's any further additional support we could have provided for this child and family, particularly on how to cope with a new significant neurodisability in a previously fit 12-year-old boy? And just overall, if you had any other suggestions of how we could improve our care towards this child and his family. So the patient details. So this was a 12-year-old boy who was diagnosed with an ischemic stroke, probably secondary to an encephalitis, but sort of diagnosis is out to debate still to this day, I would say, in the middle of January of this year. He was previously fit and well with no comorbidities. So I just wanted to talk you through the sort of events and the treatments leading to this diagnosis and the care that we gave. So it all started on about the 14th of January. He had an accidental head injury whilst playing outside. And the reports are that he just fell and hit the side of his head. It was not witnessed by his parents, but there were no red flag features for significant head injury. So there was no vomiting, there was no loss of consciousness, no drowsiness, no significant external injuries. And the reason I brought this part of the story in is just because there was a lot of mention from the various institutions that he visited that this was the cause of his neurodisability. And I'm not sure if it was actually, and I don't know whether it was a red herring, and I'll continue and show you why I feel that. The following day, he then developed a fever, severe headache, and slurred speech. And at that time, he visited a local pharmacy and took some medicine. We don't know what that medicine was. The timeline is a little bit vague between the kind of next 2.5 weeks, but it was reported that he developed left-sided spasticity, so of his arm and his leg, and there was no improvement. So the family sought medical assistance, and they went to various different hospitals. So initially, they went to a private hospital, who then referred them on to another hospital. I believe they went to a third hospital as well. In the end, they had to leave because they could not afford more treatment. Throughout this period, which was about over 2 weeks, he did have some blood tests that were entirely normal. So his inflammatory markers were all normal. He did have a CSF study, a lumbar puncture done, and that was normal. The white cell count was normal. He was treated with a short course of various treatments, including antibiotics, antivirals, steroids, anticonvulsants. Although again, the antibiotics and antivirals were not long enough to treat a meningoencephalitis. He also had a CT scan, which actually showed bilateral infarctions, one in the left cerebellum and one in the right thalamic region, neither of which really tie up with where the head injury was, which was reportedly his right temporal region. Then on the 4th of March, he was sent to us from our adults facility with a reported GCS of 3 out of 15. And he'd attended there because there'd been no improvement in his condition whilst he'd been at home. Our initial assessment actually found he had a normal cardiovascular, respiratory and abdominal examination. And actually we made his GCS to be 7 out of 15. So he did open his eyes to pain, and he did moan to pain, and he did show some flexion towards pain. And Dad actually explained to us that the eye opening was a new feature that he had not seen for the past sort of month or so. From a neurology perspective, he had significant hypertonia in both of his arms, and the left more so than the right, but he really was quite fixed in his flexion, and it was very difficult to extend his arms passively. He was hypertonic in his left leg as well, and had an upward going plantar, and he had some muscle wasting on the left side as well. The father reported that there were convulsions at home, although he was not on any anticonvulsant maintenance therapy. And he arrived at our facility with a nasogastric tube in situ, which had been inserted by a different facility, and they had discharged him with that in place. Dad had been using that at home to give fluids or diluted milk, anything he could, but with no real sort of testing behind that. Or checking that it was in the right position. So in view of the fact that he was showing some improvement, actually his GCS was 7. We admitted him into our PICU for observation for possible seizures and for supportive management. Initially, when we had heard the referral that there was a significant head injury and a GCS of 3, normally that's not something that we would perhaps provide it as an active management on, but because actually our findings were more positive than that, we did admit him. The following day, he already had shown an improvement in his GCS. He was now opening his eyes to voice. He'd had no convulsions with us in that 24 hours, and we were trying to provide some nutrition. The only sort of available stuff that we had was Formula 100, which we diluted and gave him via the nasogastric tube. The next day, he did develop a little bit of an oxygen requirement and a cough. So we treated him with nasogastric antibiotics with good effect. And we were slightly concerned about, because of his neurodisability and his inactivity, and also his significant flexion and spasticity of his upper limbs, we were worried about that. Very luckily, we had one of our doctors who had a friend that was a physiotherapist, who very kindly attended the hospital and taught Dad some exercises both for the limbs and the chest. And Dad was fabulous and did them regularly all through the hospital stay. A couple of days later, we're still seeing further improvement. His GCS is now 10. We did trial to see whether his swallow had improved. Unfortunately, it was still clearly not safe, so we had to revert back to, well, continue using the nasogastric option for nutrition. He did develop some loose stools overnight, but this was not significant and was treated successfully with ORS after each stool via the nasogastric tube. And then the following day, again, we're still seeing improvements. His GCS is now 12 out of 15. He's off oxygen and he's otherwise clinically very well and stable, aside from the fact that he still has a nasogastric tube requirement for feeding and fluids. And also, of course, he has this spasticity still. Unfortunately, the family took leave at this stage against medical advice, despite extensive discussions, which I will cover shortly. And the kind of biggest battle, I think, or biggest kind of discussion point for us as a team was, what do we do with a child with an unsafe swallow who the family will try to feed at home and that risks aspiration with every feed, versus do we let them go home with a nasogastric tube and the father is using it, although he's not checking he's not been taught how to check the position or how to aspirate, and also what happens when we need to replace the nasogastric tube or the nasogastric tube is dislodged. In the end, he went, because he left against medical advice, he actually went with the nasogastric tube in situ, and I still feel uncomfortable to this day, to be honest, with that event happening. In terms of pain and symptom management, so as I've mentioned, I was concerned about his spasticity. He was extremely hypertonic in his upper limbs. As I said, fortunately, we had a physiotherapist come, and Dad was absolutely incredible and religiously doing the exercises. We don't have any medications available. I don't feel that he needed them at that time, but I guess looking into the future, it was perhaps something at one point that he may need. Well, ideally, medications may have been helpful. Convulsions, thankfully, he had no convulsions for an entire stay in hospital. So thankfully, we didn't need to treat those. Skin care was a concern for us because of his neurodisability and not being able to actively move his body. We were worried about pressure sores. Dad was, again, amazing. He was regularly cleaning the saliva from his son's chin and neck. He would reposition his son's neck as well, and he was very caring towards the skin. And then pain, we considered pain. It didn't appear at all that he was in any pain, which was good, but we kept a very close eye out for that. The main nursing issues we faced were, again, obviously the reliance or the need to use the nasogastric tube for feeding and fluid support and antibiotics, actually. Again, the skin care and pressure sores, like I discussed, but we were doing regular position changes, both by Dad and the nursing team. And again, at physiotherapy, but thankfully Dad was able to provide all of the physiotherapy, which was excellent. Looking at the psychosocial and family concerns, so this was a Rohingya family from the camps, and as I've already mentioned, the father was extremely involved and extremely caring towards his son. He was at the bedside all the time, and he was, like I say, religiously doing the physiotherapy, caring for his son's skin, ensuring his neck was in a comfortable position. It was very admirable, actually. We did not see the mother in hospital. Sorry,
it's Janine. Sorry, I'm just thinking just a few more minutes, just because we're running kind of late. I want to make sure there's time for discussion.
Okay, I will speed up. We did not see the mother in hospital. We think that was because there were other children at home, so she was providing care to them. And Dad actually was very happy overall because he was improving clinically. His son was improving, but then started to become frustrated as to why we were keeping the child in hospital. Spiritual concerns. So the main thing that became apparent was the family really wanted to see a traditional healer, and we suggested that a healer could come to us in PICU as long as they didn't give any IV or oral medications. And initially the family were on board with this, but then unfortunately changed their mind and decided to leave. Communication. So on the day that he arrived in our ER, we had a very detailed discussion. The father arrived with a lot of paperwork from different hospitals, and we really needed to know what his understanding of the disease was and the potential prognosis. Then as he stayed for a few days, we needed to involve our extensive multidisciplinary team. The health promotion team came, the mental health team, our doctors and our Rohingya translators came, first of all to discuss about going to the traditional healer. And then when it became clear Dad wanted to leave the hospital, again, we had extensive discussions explaining why we didn't feel it was appropriate for him to leave yet. And given that his clinical status was improving every day, we were hopeful that he would continue to improve. Obviously, a big challenge for us was the previous institution had discharged him with a nasogastric tube in situ and no clear training of how to use that nasogastric tube. So from the family's perspective, it was unclear to them as to why we were less keen to let them be discharged. Eventually, even despite our best efforts and extensive discussions, the family did leave. They said they would come back after seeing a healer, but unfortunately they didn't come back. I've kind of I won't go into detail about the team, but you know which team was involved, as I've mentioned them all in their roles already. So just to summarize the case, it was a 12-year-old boy that was previously fit and well, who suffered ischemic strokes with unclear etiology, but possibly infectious, developed forelimb involvement with marked spasticity, particularly of his upper limbs, and also weakness and wasting of his lower limbs. He had an unsafe swallow and relied on nasogastric tube for nutrition and fluids. And we found this case particularly challenging because a previous institution had discharged him with a nasogastric tube. So that meant that the family struggled to understand why our opinions differed from the previous institution. And we were concerned about the sort of care and training of a nasogastric tube in the community. And I will leave you on the final slide, which you have seen before, which is just the questions that we had whilst managing this case. Thank you very much.
Thank you, Lucy. Sorry to rush you through. So can people please respond to these questions in the chat, or stick up your hand or unmute? There is some activity in the chat about the use of anti-spasticity drugs. There is an outstanding question about whether IV diazepam can be used orally in the pediatric setting. And maybe one of the pediatricians can respond to that. So should we start with the first one? How do we safely provide nutrition to this child? What are people's thoughts about that?
So maybe I can just comment, because it's very common that we see this. And I just want to say to Lucy that the more you start doing palliative care for children, the more these kids get picked up. It starts to be more and more something that you have to face in terms of how do you manage these patients where you know they can't swallow well, or they've lost the ability to swallow. So there's no right answer, okay? There are a number of things you can do. It really depends on your situation and like the whole thing, and you as a team and what the team can provide, what the family can do. It is reasonable to teach them how to manage the NG tube and send them home. There are risks. But there are a lot of risks to not having, if he doesn't have an NG tube, essentially he's gonna die. So, and if they really want that, then I don't think it's totally unreasonable to send them home with it. Yeah, they can't check position all the time. That's okay. We accept that in these kind of settings. Like, we do have patients at home with NG tubes. They don't check the position all the time. They go clinically. You train them that if the child's like coughing, sputtering, like, please stop. And some of them get very good at it, even in very resource limited settings. And you supply them with the formula, or you teach them how to make something. The major mistake that people make, like families make when giving NG feeds at home in these settings, is that they give stuff that's basically just too watery and doesn't have any nutrients. Like, they'll just give like the water from boiled vegetables, like with a little bit of rice mixed into it or something, and they think all the nutrients from the vegetables have gone into the water, but like boiled vegetable water is just water, basically. So you have to train them to like increase the calories in stuff with like whatever are the options in your setting. Like, if you have to add micronutrient, like if they have micronutrient sprinkles, you can dissolve and add, or milk or whatever. But that part usually isn't a problem. Just teaching the family something appropriate. Otherwise, left to their own devices, they don't choose the right thing. So yeah, and if you just tell them if the tube falls out, just come back to the emergency room or like the OPD and you just put it back in. And you tell them that like can stay in 6 weeks and then then they should come back for reassessment and replacement. Definitely, yeah, there's no blenders. So, and Erin is saying about like, how do you get the food to the right consistency? Yeah, so families do it, no problem with just, you teach them, like if you cook the food well, like sort of a khichdi style dish, which is like rice, dal, some vegetables, some oil mixed, and then you just need to dilute it to the right consistency. So usually the key is just to not dilute it with just plain water, because then it gets to be half the calorie or half the volume is just water. To dilute it with like milk, if they can access milk, like powdered milk, or dilute it, do some of the dilution with oil. Then usually that's how they do it. The other option is no NG and just send them home and they just sort of sink or swim basically. Because for our babies with cerebral palsy, we try to send them home without NG tubes and just see how they're going to manage. And if they can swallow, they can live. And if they can't swallow, like, you know, it's hard to live. So I'm not an advocate for the NG tubes, but once it's in and you're already in this situation, then usually you have to keep going with it. So you're kind of already down the path of using an NG tube, I would say. So.
Great, thanks, Megan. Zanat, you had your hand up. Would you like to unmute and make a comment?
Yeah, thank you. Thank you, presenter, for your elaborate and excellent presentation. And certainly it's a very, am I audible? Certainly it's a very challenging position for both families and for the palliative care teams. And families, as a challenging position is this because they're not very much known to this situation. And they're doing a family is also a challenging position for them. So I think what Dr. Megan has said, excellent talk. She has given some direction. I just want to add two things in our situation in this country. I just want to say that the food they have to take, they have to give a child. If I teach them very easily and make it or show it, it will be better for them. And why we want to give this kind of food? What would be the better for the child? If I say, if we can say or I can explain to them, it will be better for them. And they have to give some positivity for why this food is needed for this bond. And another thing I just want to add that physiotherapy has a great role here. So they are not that much vulnerable with this physiotherapy. It is possible if we can give different type of exercise in different ways. And if there are any home service team, home-based team service related, it would be an excellent because improvement of this child may be a longer duration. So family has to, I think, should in this way. Yes, longer duration we need for rather more betterment. I think this kind of points can be discussed with the family, other than all the psychosocial or the
Great, thank you, Zanat. There's other comments in the chat about how to manage the NG. And Kathryn, you have your hand up.
Thanks, Gillian, and thanks, Lucy, for presenting this case. I just wanted to give you an additional tip, which might be quite supportive for families with children with chronic illnesses like this. And I think if you can work with the family, because I know we have the leave against medical advice, the LAMA discharge, but it can be quite upsetting sometimes for families to think they're going against medical advice. And actually what we always try and do in palliative care, and I think this can be used, I think, in other settings too, is to try and work with the families. So rather than making them feel that they are not following our advice and they're going home, sometimes, and I remember situations when I've been in your situation where you might feel a bit of anxiety, right, about sending this family home, and you're not sure how it's going to work out. So you want to keep this child for observation while you're trying to work out your plan. But sometimes the family might feel that, well, actually nothing's really changing. He's not getting better. Maybe not much is happening here in the hospital, and it might be valid that they actually feel like they want to go home. And so just a tip that can be, I think, really helpful for families is to try to find a way forwards together. And I think, I'm sure you did this, but it also helps in the sort of way we talk about it in a team and thinking about leaving against medical advice. We try to rephrase it or reframe it as, we negotiated our discharge to be like this, and it just is a bit more supportive, and that family feels supported. They're already dealing with quite a difficult situation, and I'm sure your communication was very good, Lucy, but they're already dealing with quite a difficult situation, so it's just about how we can collaborate and find a way forwards together, even if it's something that you feel a bit anxious about. Does that make sense?
Yeah, no, definitely.
And that was it.
Thanks, Kathryn. So maybe in the last couple of minutes, can we think about the last two parts of the questions? What additional support could be provided, and any other suggestions? Any thoughts about that?
I could just comment on the caregiver. It sounds like the father is really one of the reasons why the child has lived up until this point, because he's advocating and taking such good care. But at some point, just identifying maybe he is going to burn out. So if there is a neighbor, or sounds like maybe the mother is at home, but just helping the father identify that there might come a point where it's going to be very overwhelming for him. So because he's the biggest advocate at the moment, if there's a way to sensitively talk to the father and see if there's someone that he could find in his support network that could help him. Because it sounds like the child might be requiring a lot of care for the next foreseeable future. So
Thank you. Lucy, any last words before we hand over to Tasneem? No?
No. Thank you very much for your comments and thoughts, everyone.
Lovely. Thanks very much. So at Tasneem, I'm going to hand over to you for the Bangladesh summary, please.
Thanks, Gillian. Assalamu alaikum everyone. আমি আজকে আমরা প্যালিয়েটিভ কেয়ার নিয়ে শুনেছি। প্যালিয়েটিভ কেয়ার একজন অথবা যে রোগী HIV AIDS এ ভুগছেন তার জন্য প্যালিয়েটিভ কেয়ারের প্রয়োজনীয়তা কি বা কিভাবে আমরা প্যালিয়েটিভ কেয়ার সেবা দিতে পারি। ডক্টর ক্যাথরিন প্রথম আমাদেরকে যে প্রেজেন্টেশনটি বলেছেন সেটা থেকে আমি কিছু লাইন হাইলাইট করব আপনাদের উদ্দেশ্যে। প্রথমটা হচ্ছে বিশ্ব স্বাস্থ্য সংস্থা বা WHO অনুযায়ী বলা হয়েছে যে প্যালিয়েটিভ কেয়ার HIV AIDS রয়েছে এরকম রোগীর ক্ষেত্রে ইন্টিগ্রেশন করার প্রয়োজনীয়তা রয়েছে এবং প্রতিটি ধাপেই। আমরা আজকে একটা কথাও শুনেছি যে যদি খুব খারাপ অবস্থা না হয়ে থাকে সেক্ষেত্রে প্যালিয়েটিভ কেয়ারের প্রয়োজনীয়তা রয়েছে কিনা, সেক্ষেত্রে আমি আবার নিশ্চিত করছি WHO বিশ্ব স্বাস্থ্য সংস্থা অনুযায়ী জি, প্রতিটি স্টেজেই HIV AIDS এর ক্ষেত্রে আপনাকে প্যালিয়েটিভ কেয়ারকে ইন্টিগ্রেট করতে হবে। এই ইন্টিগ্রেশনটা কিভাবে হবে? আমরা যখন রোগীর সিমটম বার্ডেন অথবা রোগীর যে কষ্টগুলো রয়েছে সেগুলোকে কমানোর চেষ্টা করব, লক্ষণ সমূহকে। যখনই আপনি লক্ষণ কমাবেন সেক্ষেত্রে রোগীর জীবনের মান উন্নত হবে এবং এই ডিজিজটাকে, এই রোগটাকে আমরা ফেলবো হচ্ছে এটা পুরোপুরি ব্যবস্থাপনার ভিতরে। সেটা হতে পারে রোগীর শারীরিক, মানসিক এবং সামাজিক এবং আত্মিক, এই সবগুলো বিষয়কে নিয়ে। এবং আরো একটি বিষয় সম্পর্কে বলা হয়েছে, সেটা হচ্ছে জীবনের শেষ সময় সেবা। আপনাদের প্রতি দুটো প্রশ্ন ছিল, একটা হচ্ছে আপনি HIV তে ভুগছে এরকম কোন রোগীকে দেখেছেন কিনা, অথবা অ্যাডভান্সড HIV রয়েছে এরকম কাউকে দেখেছেন কিনা এবং তাদের কি ধরনের সমস্যা রয়েছে। আমরা যখন সমস্যা বা লক্ষণগুলোর ব্যাপারে কথা বলেছি সেক্ষেত্রে দেখা গেছে সমস্যাগুলো হতে পারে তার HIV রয়েছে এই কারণে সমস্যা, তার ইতিমধ্যে অপরচুনিস্টিক ইনফেকশন, আমরা ওরাল ক্যান্ডিডিয়াসিস, থ্রাশ এরকম অনেক কিছুর ব্যাপারে শুনেছি, সেটা একটা হতে পারে। অথবা সে যে চিকিৎসাটি পাচ্ছে সেই চিকিৎসার জন্য তার কি কি সমস্যা হচ্ছে। এক্ষেত্রে বলে রাখা ভালো, কেউ কেউ অ্যান্টিরেট্রোভাইরাল থেরাপি যারা পাচ্ছেন তাদের ক্ষেত্রে কি কি ধরনের সমস্যা রয়েছে কিছু উদাহরণ আমাদেরকে বলা হয়েছে, যেমন মাথা ব্যথা, সাইকিয়াট্রিক কিছু সিমটমের কথাও বলা হয়েছে, শ্বাসকষ্ট এবং কাশি দেখা গেছে টিউবারকুলোসিসে ভুগছেন এরকম রোগীদের ক্ষেত্রে, যেহেতু এটা একটা অপরচুনিস্টিক ইনফেকশন। আবার বলা হয়েছে ব্লাইন্ডনেস, সাইটোমেগালোভাইরাস রেটিনাইটিস থেকে ব্লাইন্ডনেস বা অন্ধত্বের কথা বলা হয়েছে, এমনকি রক্তশূন্যতার কথাও বলা হয়েছে। আমরা যখন ব্যথার ব্যাপারে কথা বলবো, ব্যথাটা হতে পারে আবার সেই একই দিক থেকে আসছে। এই রোগীটির যদি HIV AIDS এর সাথে সাথে রোগীর যদি কোনো ধরনের সেকেন্ডারি ডিজিজ, সেটা হতে পারে ক্যান্সার বা ম্যালিগন্যান্সি থেকে থাকে, অন্য কোনো কন্ডিশন ইতিমধ্যে এই রোগী ভুগছেন সেটা থেকে হতে পারে, অপরচুনিস্টিক ইনফেকশন থেকে হতে পারে, এবং আরো অনেক ধরনের প্যাথোলজি তার শরীরে থাকতে পারে, সেখান থেকেও হতে পারে। আমরা যখন ব্যথার ব্যাপারে কথা বলেছি তখন ডক্টর আমাদেরকে সাজেস্ট করেছেন আমরা WHO যে স্টেপ ল্যাডার প্যাটার্নটি রয়েছে সেটি অনুযায়ী আমরা মাইল্ড, মডারেট এবং সিভিয়ার পেইনের জন্য আমরা ব্যথানাশক প্রয়োগ করব। এবং অন্য যে সিমটমগুলো রয়েছে সেগুলোর ভিতরে ফ্যাটিগের কথা বলা হয়েছে, কারো কারো ক্ষেত্রে ডায়রিয়ার কথা বলা হয়েছে, নাউসিয়া, গিলতে কষ্ট হওয়া এবং স্কিন অনেক ড্রাই হয়ে যাওয়া, স্কিনে চুলকানি থাকা, এই ব্যাপারগুলোর কথা বলা হয়েছে। আমাদেরকে আরো বলা হয়েছে রোগীটিকে যথেষ্ট পরিমাণে সাইকোসোশ্যাল এবং স্পিরিচুয়াল সাপোর্ট দেওয়ার কথা। কিছু স্টিগমা বা ডিসক্রিমিনেশন আমাদের সমাজে থাকে, সেই ব্যাপারে রোগীকে জানানো এবং নিজে জানা, ভয়টাকে কাটিয়ে উঠতে সাহায্য করা এবং রোগীর সাথে সরাসরি কথা বলা যে কোন বিষয়গুলো করলে আপনার জন্য ভালো হবে, কিন্তু কখনোই এরকম কোনো আচরণ না করা যে আপনি সম্পূর্ণরূপে ভালো হয়ে যাবেন বা এই রোগটি নিরাময় হবে। মিথ্যা আশ্বাস না দিয়ে সঠিক যে যা যা ঘটতে পারে সেই বিষয়ে রোগীকে জানানো। অনেক সময় দেখা যায় রোগের ধারাবাহিকতা খারাপের দিকে অথবা আপনি ধারণা করতে পারেননি এরকম খারাপ হয়ে যেতে পারে, সেক্ষেত্রে নিজেকে প্রস্তুত রাখা এবং রোগী এবং রোগীর লোকের সাথে কথা বলার ব্যবস্থা করা। কিছু কিছু ঔষধ আপনার প্রয়োজন হতে পারে জীবনের শেষ সময়ের সেবায় ব্যবহার করার জন্য, সেই ব্যাপারে সচেষ্ট থাকা। কিছু কিছু ঔষধের ক্ষেত্রে আমরা দেখতে পেয়েছি অ্যান্টিরেট্রোভাইরাল ড্রাগের সাথে বিক্রিয়া ঘটায়, সেক্ষেত্রে একটি ড্রাগ চেকিং এর কথা বলা হয়েছে, একটি টুলস এর কথা বলা হয়েছে। আমাদের আজকের লেকচারে সেটি ছিল, আপনারা এই টুলসটিও চেক করে দেখতে পারেন। পরবর্তীতে আমরা যেই লেকচারটি দেখেছি, কেস প্রেজেন্টেশনটি দেখেছি, কেস প্রেজেন্টেশনে আমরা পেয়েছি 12 বছরের একজন মোটামুটি সুস্থ শিশু, যিনি ইস্কেমিক স্ট্রোকের কারণে, কি কারণে স্ট্রোকটি হয়েছে আমরা জানি না, পরবর্তীতে দেখা গেছে তার 4 হাত পাতেই স্পাস্টিসিটি ডেভেলপ করেছে, অনেকটা শক্ত হয়ে থাকা ধরনের প্যারালাইসিস এরকমটা ডেভেলপ করেছে। সেক্ষেত্রে এই রোগীটাকে আমরা কিভাবে সাহায্য করতে পারি এই ব্যাপারে ডিটেইলস আলোচনা করা হয়েছে, আপনাদের মতামত চাওয়া হয়েছে এবং শারীরিক ব্যাপারগুলোর পাশাপাশি সাইকোসোশ্যাল এবং ফ্যামিলি কনসার্নগুলোর ব্যাপারেও বলা হয়েছে, যেমন সে কি ধরনের পরিবার থেকে এসেছে, তার পিতা অনেক বেশি আপসেট ছিলেন তাকে নিয়ে। আমরা কিছু আলোচনা থেকে জানতে পেরেছি খাবারের জন্য তার কি কি করা যেতে পারে, কিভাবে তাকে নিউট্রিশনাল সাপোর্টটি দেওয়া যেতে পারে, এমনকি নার্সিং কিছু ইস্যুর কথাও বলা হয়েছে। স্কিনের ক্ষেত্রে আমরা কি ধরনের কেয়ার নিতে পারি, ফিজিওথেরাপির ক্ষেত্রে রোগীর পরিবার, ফিজিওথেরাপিস্ট ছাড়াও রোগীর পরিবার কিভাবে কাজে আসতে পারেন, এই ব্যাপারটি প্যালিয়েটিভ কেয়ার লক্ষ্য করতে পারে। ধন্যবাদ।
Thanks, Tasneem. There's been quite a lot of stuff in the chat about medication management, etc. So thanks to everybody. Thanks, Kathryn and Lucy, for presenting, and Tasneem for doing the summary. So the next session is April 8th on neonatal palliative care. Megan's doing that one. So any other burning comments, questions? Megan, Kathryn, anything you guys want to add?
No, I just maybe request, I don't know, Lucy, if your team can do a case for neonatal, if you guys have one, or we'll just reuse a previous one. But if you have any new case you want to bring that's like challenging neonatal palliative care, we'd love to hear it. It's not too much trouble for you or anyone else if they want to have a case you want to present.
Okay, great. Thanks, everybody. See you next time. Bye.